My name is Sarah Sunshine. I'm an assistant professor of ophthalmology at the University of Maryland School of Medicine in Baltimore. I'm going to be speaking with you today about sharing ocular surface disease, pathophysiology, evaluation, management with topical agents, and neuromodulation. I want to thank both MedNet and Dompé for their support for this talk. This is the information about the how you can get CME credit for this through multiple different opportunities, and there will be more information on that. So to receive CME, please attend the webinar completely. After the webinar, you'll be able to participate in a brief evaluation and download your certificate. There will be a link displayed at the end of the program. Please remember to complete the evaluation by September 8th, 2025. This is our disclosures policy. And then this is my personal disclosures. None of them are relevant to this talk, as well as the disclosures for Medco and MedNet. And then this is just a disclosure saying that there are medications that are that we discussed that are off-label, so please be aware of that. And then the learning objectives. So the goal is to summarize the pathophysiology, risk factor, and evaluation of ocular surface disease, and to interpret data on artificial tear formulations and neuromodulation in managing ocular surface disease. And the agenda for today, so there's going to be two halves to this presentation. We're going to start off with a pre-test, which is a clinical vignette, and there will be an opportunity to answer that through a poll. And then we're going to discuss the pathophysiology, risk factors, and evaluation of ocular surface disease. Then there will be a post-test where we'll review the pre-test, and then we'll go into a second pre-test clinical vignette. And then we're going to discuss current and emerging management options for ocular surface disease. And then there will be a post-test question. And then at the end, there will be a question and answer session where you'll have the opportunity to ask questions and we can have a bit more of a discussion. So this is the pre-test question with the clinical vignette. This is the past medical history is a 58-year-old man with a history of atopic dermatitis, asthma, allergy, and end-stage glaucoma. He's currently on maximal medical therapy for his glaucoma and a history of multiple ocular surgeries, including glaucoma surgeries, and he presents with bilateral corneal scars, which you can see here. So the question is, what is the most likely cause of corneal scars? A, limbal stem cell deficiency, B, burn, C, herpetic infection, D, medication toxicity, E, allergy, and F, A, D, and E. I'm going to give you a moment to answer that question for us. Okay. So to begin, we're going to start talking about the pathophysiology and risk factors of ocular surface disease. Just a brief overview of the plan for this talk. We're going to talk about the anatomy, ocular surface and tear film specifically, the definition of ocular surface disease and dry eye disease, and then we're going to go into some disorders of the ocular surface, specifically focusing mainly on dry eye disease, but I'm going to touch briefly on Sjogren's, neurotrophic keratitis, blepharitis, and meibomian gland disease, and ocular graft versus host disease. So what is the ocular surface and what's included in the anatomy of the ocular surface? When we think about the ocular surface, we want to think about the tear film, the lacrimal gland, the conjunctiva, including both the epithelium and goblet cells. You also want to think about all the layers of the cornea, including the epithelium, stroma, endothelium, and also the corneal nerves are really important, as well as the eyelids, both the glands within the eyelids, as well as the blinking action. And then you also want to think about the immune system, both the innate and adaptive immune system. So to start off with the tear film, the tear film is really a critical component to the ocular surface. It has the air-tear interface has the highest refractive component of the eye, and the tear film classically has three different layers: the lipid layer, aqueous layer, and mucin layer. So the lipid layer is produced by the meibomian glands, the aqueous layer is produced by the lacrimal gland, and the mucin layer is produced by the goblet cells. Classically, they were thought of as three different components to the tears. More recently, it's better understood as more of a mixture of all of these components, and we're going to go into each one individually so we can better understand these. So lipid secretion from meibomian glands. The lipids are really important for preventing evaporation, so keeping the tears on the eye. They create a smooth optical surface with that air-lipid interface, and they stabilize the tear films on the surface of the eye. It also enhances spreading of the tear film and seals the lid margins during sleep, so when the eyes are closed, it allows the tears to stay on the surface. Meibomian gland dysfunction is the #1 cause of dry eyes and is really important to think about when you're thinking about ocular surface disease. The lacrimal glands produce the aqueous component. The aqueous component has most of the proteins found in the tears, including lactoferrin, lysozyme, secretory IgA, and epidermal growth factor, to name a few. And then there are other components of the aqueous secretion. There's a basal tear secretion from the glands of Krause and Wolfring, and reflex tearing is still from the main lacrimal gland. And then the mucin layer, its main functions are to stabilize the tear film, lubricate the surface of the eye, and there's also a protective component to the mucin layer where it protects the eye from the cornea from bacteria and creates a smooth refractive surface. There are multiple components to this, but it's produced by the goblet cells, which make up about between 5 and 20% of conjunctival epithelial layer. These cells are what secrete the mucin, mucin 5AC, and then there are large membrane-bound glycoproteins like glycocalyx, which also have an important role where they convert the corneal epithelial surface from a hydrophobic to hydrophilic surface, which is important to allow the tears to stay on the eye, and they also prevent bacterial adhesion and increase lubrication. So all of these components are important, but what is the definition of dry eye disease? So the TIFOS DEWS 2 was a consortium of ocular surface disease experts who came together to define dry eye disease. There was TIFOS DEWS 1, now there's TIFOS DEWS 2, and there is a third iteration of this that will be available, but is not yet. So our definition is that dry eye is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play an etiological roles. So this is really the framework in which we can understand dry eye disease and ocular surface disease. So again, this is still from TIFOS, and it's really important when you're thinking about ocular surface disease is how to classify it and how to make sense both clinically and systematically. So they recommend starting with a more clinical approach where you see the patient. So there's a presentation of the patient. You can determine whether or not they're asymptomatic or symptomatic, and then you look at the signs of ocular surface disease, and then you can characterize them into different components. So you want to think about dry eye disease is a symptomatic patient with ocular surface signs, and then you have other ocular surface diseases like ophthalmos. So those are patients that are symptomatic with signs of ocular surface disease. You can have a neuropathic pain component, which are patients with symptoms without signs. And then you can have preclinical patients with dry eye disease, which have symptoms without signs without symptoms. And then you can have a decreased corneal sensation where they have they don't have symptoms of dry eye disease, but they have a significant signs on exam, and that's due to corneal nerve damage. And then you have patients with predisposing risk factors for dry eye disease. So these are the things that you want to try and think about when you're presented with a patient with ocular surface disease. That's the top half of this, this figure here. Then you want to think about classifying them in a slightly different way and more of which component of dry eye disease they are. So there's aqueous deficient dry eye disease and evaporative dry eye disease. Most patients have both components, so it's more of a spectrum as opposed to defining a patient as either aqueous deficient or evaporative. But it's important to think about this because it's easy to once you figure out which component is most prominent, you're then able to focus the treatment for the patient on that particular piece of it. So for aqueous deficient dry eye disease, you want to think about that's more involving the lacrimal gland and challenges with tear production. And then evaporative dry eye is more focused on the eyelid and the diseases like meibomian gland disease or challenges with blink or contact lens overwear, which really changes how you want to manage these patients. Again, most patients are in the middle somewhere involving both an aqueous component and evaporative. So what is the pathophysiological mechanism of dry eye disease? As you can see from these figures, it's really there's a lot of different components. There's a lot of different causes and things that can exacerbate dry eye. But ultimately, the mechanism is really complicated and not totally understood yet. But there are a lot of pieces that go into this. So to break it down a little bit, the way that I like to think about it is that there's this cyclical component to dry eye disease, which involves both irritation, inflammation, and tear instability or deficiency. And there are different things to think about in all of those areas. This does by no means encompasses all of ocular surface disease or dry eye disease, but there are parts to think about here. So you want to think about the environment, other both systemic and topical medications, contact lens history, surgical history. You want to think about the inflammatory component, whether there's an underlying medical cause or a medical history that's important to note. And then you also want to think about other components that can cause tear deficiency, like hormonal imbalances, meibomian gland disease. And then all of these come together to result in the symptoms of ocular surface disease. So what are the disorders of the ocular surface? We're going to focus most on dry eye disease, but there's also neurotrophic keratopathy, meibomian gland disease and blepharitis, limbal stem cell deficiency, filamentary keratitis, and ocular graft versus host disease. We are going to go through some of these, and this isn't all of the ocular surface diseases. There are many more, but this is a good sampling. So what is dry eye disease? So the risk factors for dry eye disease include advanced age. There's a increased predilection in female. There's a increased with hormonal imbalance. Abnormal corneal innervation increases your risk for dry eye disease, which can be caused by multiple different things. You can have vitamin deficiency, contact lens use or overuse. Infection of the cornea can cause dry eye disease or other infections, and then history of ophthalmic surgery, both refractive or any kind of ophthalmic surgery can cause dry eye disease. What are the symptoms? You can have dryness, irritation, a foreign body sensation. You can even have light sensitivity and itching. But it's important to think about that patients with dry eye disease are more likely to experience symptoms of anxiety and depression. So this is really a multifactorial disease that really can can be very debilitating for our patients. And it affects a lot of people. So more than 5 million Americans 50 years and older have dry eye disease. 2/3 of them are women. You can also notice that it's starting to affect people at a younger age, especially with the increased use of devices, and screen time has increased both in a younger population and is a pretty regular part of life now, which increases the incidence of dry eye disease younger. So next we're going to shift focus a little bit and talk about Sjogren's syndrome. This again is increased in females more than males, 10-to-1 ratio, which is higher even than dry eye disease. There's a primary and secondary component. So primary does not have autoimmune disease. Secondary is associated with other autoimmune diseases like rheumatoid arthritis or lupus. You make the diagnosis based on history, so a history of dry eye or dry mouth, ocular signs, including a Schirmer's test, fluorescein staining, tear breakup time, and we'll go into more details on all of those. And then you can get a histopathological diagnosis, and then you can look for autoantibodies such as SSA and SSB. And then you can have ocular complications like filamentary keratitis, which you can see in this photo above. You can have sterile ulcerative keratitis, which can cause thinning and perforation. And you want to remember to avoid topical NSAIDs in these patients. It's something really important to think about, especially after cataract surgery, where NSAIDs are often used. And you also want to remember that these patients are at increased risk of microbial keratitis. And treatment for Sjogren's includes topical and systemic immunosuppression, punctal occlusion, and increased lubrication on the surface of the eye. Neurotrophic keratitis is another ocular surface disease. There are multiple different causes of neurotrophic keratitis, including infectious causes. The treatments can include preservative-free artificial tears, serum tears, punctal occlusion, bandage contact lenses. A lateral tarsorrhaphy is something that you want to think about and can be very beneficial in these patients, as well as contact lenses or scleral contact lenses, and treatments like oxervate, which can increase which is recombinant human nerve growth factor. And it's really, so why are corneal nerves so important? There's lots of evidence that the corneal nerves are critical to the health of the epithelium. So they work together, and it's this cross communication that's really critical for a healthy epithelium. There are different stages of neurotrophic keratitis. Ultimately, you want to treat this in a stepwise fashion, but you want to, so stage 1 is with corneal epithelial irregularity. Stage 2 has a persistent corneal epithelial defect, usually with rolled edges. And then stage 3 is a corneal ulcer, and can lead to corneal perforation and corneal stromal melting. The treatments is you want to think about stopping all topical medications that are not necessary, switching and converting the medications to preservative-free formulations, and then treating ocular surface associated diseases or inflammatory diseases. You can also think about corneal or scleral contact lenses. A tarsorrhaphy can be incredibly helpful in these patients. Amniotic membrane transplant. If you're worried about perforation, you want to think about glue with a bandage contact lens, a tarsorrhaphy, and in the worst case scenario, you want to think about full thickness or a lamellar keratoplasty. You also, again, there are newer medications like oxervate that can be helpful for this. So I already went through this, but again, preservative-free artificial tears, serum tears, punctal occlusion, bandage contact lenses, lateral tarsorrhaphies, and scleral lenses. You can also think about more other therapies like oxervate, corneal transplant, or corneal neurotization surgery, which is the transfer of the supratrochlear or supraorbital nerves directly to the limbus. This has a fairly good prognosis. It's pretty new. It is a more complicated surgery and can take some time to actually take effect, but it is an option to think about. Blepharitis is another ocular surface disease that you want to think about with chronic inflammation of the eyelid margin. You can break this down into anterior and posterior. Anterior is more staphylococcal and posterior is more focused on the meibomian gland dysfunction. You can have a hypersecretory or seborrheic meibomian gland dysfunction or a hyposecretory meibomian gland dysfunction with meibomian gland plugging and loss of the glands. And again, just like dry eye disease, you can have a more mixed component to this, where it's patients have multiple different components at play at any one time. So just to look at it one other way, so staphylococcal blepharitis, you can have crusting or collarettes, and you want to treat these patients with eyelid hygiene and topical antibiotics. Then seborrheic blepharitis, you see more of an oily or greasiness to the lashes, and you want to think about whether or not these patients have seborrheic dermatitis elsewhere on their body. This is treated like seborrheic dermatitis, where you use lid hygiene specifically with selenium shampoo. And then meibomian gland disease has inflammation of the meibomian glands, blocked meibomian glands. You can see telangiectasia along the lid margin, foamy tears, and you can also see marginal corneal ulcers where the eyelids sit on the cornea, and an unstable tear film, so a rapid tear breakup time. Again, we'll go through all of the different diagnostic tools. And these patients often complain about burning, watering, or blurring of their vision. Meibomian gland disease therapy, you want to think about lid hygiene, so warm compresses or eyelid scrubs, antibiotic therapy with erythromycin ointment at bedtime or azithromycin topically. You can also think about a combination of a steroid and antibiotic. And then you can also try doxycycline, so a systemic therapy antibiotic that has both anti-inflammatory and antibacterial components to it. This is a more chronic therapy for usually you want to think about treating them for 3 months. And then this can also lead to more liquid secretion of the meibomian glands, so that's helpful. And finally, I want to touch on ocular graft versus host disease. So this affects patients who have undergone a allogeneic hematopoietic stem cell transplant for the treatment of blood-related cancers and or hematologic malignancies. This is where the new donor immune cells from the stem cell transplant attack the host tissue. It affects the eyes as one area of the body, but it can also affect the skin or the gut or multiple other areas. And it affects about 50 to 100,000 patients in the United States and affects about 50% of patients after a stem cell transplant can ultimately get ocular graft versus host disease. The ophthalmic complications are most prominent with dry eye disease and meibomian gland dysfunction. So the signs include it's a severe inflammatory dry eye disease. So they have severe dry eye, infection, increased risk of an infection, increased pain, decreased vision. You get the cicatricial conjunctivitis. And in worst case scenarios, you can have corneal perforation. And it's been shown to really hinder the quality of life in these patients. We have a diagnostic criteria, which was described by the International Consensus Criteria on Chronic Ocular GVHD, which requires an eye exam by an ophthalmologist. It takes into account whether or not the patients have systemic graft versus host disease or not. And then it looks at the Schirmer's test, which is a measurement of tear production, corneal fluorescein staining, ocular surface disease index score, which is a validated dry eye questionnaire, and then the injection of the conjunctiva. We treat this similarly to how we treat or think about many of the ocular surface diseases. You want to think about replacing the moisture with preservative-free artificial tears, treating the meibomian gland disease with warm compresses, erythromycin, and doxycycline. You want to prevent loss of fluid from the eye with contact lenses, moisture chambers, environmental changes, and then you also want to control the inflammation, both topically with steroids or tacrolimus or cyclosporin, and systemic therapy with steroids or tacrolimus or rituximab, and that's usually done in collaboration with oncology. We still need better diagnostic and treatment options for these patients. In the next lecture, we're going to talk about the diagnostic approaches and the management in more detail of ocular surface disease. But that is the last part of the this first half of the lecture. So we're going to go through that post-test clinical vignette again. So again, this is a 58-year-old man with a history of atopic dermatitis, asthma, allergy, and end-stage glaucoma on maximal medical therapy for his glaucoma, and a history of multiple ocular surgeries, including glaucoma surgeries, who presents with bilateral corneal ulcers, which you can see here. So again, the question is, what is the most likely cause of corneal scars? And we'll give you a few minutes here to answer that question. So the options are limbal stem cell deficiency, burn, herpetic infection, medication toxicity, allergy, or limbal stem cell deficiency, medication toxicity, and allergy. So that's great. So a number of people, so 70% of people got this question correct. The correct answer is F. It includes limbal stem cell deficiency, which you can see from the photo, which is likely due to multiple etiologies, including the medication toxicity, a history of allergy, and an atopic history, as well as the multiple surgeries, especially the glaucoma surgeries, can all lead to the corneal scars that we're seeing in this patient. So great job. So we're going to continue on to the second half of this talk with the pre-test clinical vignette, the second one. So this is a 74-year-old female who came in from neurosurgery with a history of diabetes. She underwent a left cavernous sinus tumor resection in August and presented with blurred vision, double vision, sixth nerve palsy, and presented to the cornea clinic 1.5 months after the surgery. Her exam, the right eye is normal with 20/20 vision. The left eye is 2500 vision. In the cornea in the left eye, it has an inferocentral epithelial defect with rolled edges and a surrounding corneal haze. Corneal sensation was absent in the left eye. There's a central epithelial defect measuring 3 by 4 millimeters and a poor blink. So what treatment would you recommend? A, preservative-free artificial tears, B, bandage contact lens, C, moxifloxacin, D, culture, E, amniotic membrane graft, F, autologous serum eye drops, G, scleral contact lenses, H, tarsorrhaphy, and I, oxervate or sinogermin. And for this question, you want to think about what treatment would you recommend first? So we're gonna okay. So we're gonna start with current and emerging diagnostic and management options for ocular surface disease. Okay. So we're going to start with going through the diagnostic tools available for ocular surface disease diagnosis. We're going to talk about the management options for ocular surface disease, and time permitting, we're going to go through a case presentation which can highlight both the complexity of managing these patients and also how some of the available tools for managing these patients. So diagnostic tools for ocular surface disease. The way I like to think about these patients is in the clinical evaluation is to start with the history and symptoms. So you want to know when the symptoms started, what the symptoms are. I like to use a validated questionnaire like the Ocular Surface Disease Index score. And then you also want to think about the past medical history. It's really important to think about to ask the right questions, or else you're not going to get all of the information that you need to come to the right answers. You also want to then you want to move on to the exam, which includes both the external ocular and slit lamp exam. So you want to look at multiple different components of the ocular surface. So like we talked about, you want to think about look at the eyelids, the lid margins. You can get a lot of information from that. You want to look at the conjunctiva and the cornea, and as well as the remainder of the eye exam. As far as clinical tests, which is what we're going to focus on here, there are a number of different options, including ocular surface staining, tear breakup time, Schirmer's test, which is a measurement of tear production, a fluorescein clearance test, tear fluid osmolarity test, measurement of MMP9, which is available as inflammadry, and corneal sensation esthesiometry, and meibomian gland imaging. So we're going to start with tear breakup time, both how you do it and what it tells you. So you place a drop of fluorescein in the eye. I like to use the fluorescein strip as opposed to fluoresce. And you want to make sure to use balanced salt solution or non-preservative tears, because an anesthetic can change how this test functions. And then you have the patient blink, and then you look for the dry areas on the cornea and you count how long that takes. I like to do it 3 times and then average those. Normal is more than 10 seconds. So what you can see here is that there's a clear surface, and then you can see that the surface breaks up. Then you want to think about ocular surface staining. So there are 3 main types of ocular surface staining. You have fluorescein, rose bengal, and lissamine green. I break this up really into 2 different parts. So fluorescein stains the area of the missing epithelium. So epithelial defects or erosions are highlighted. Fluorescein can permeate inside the cells, which can make it harder to see the cornea as well. And then you can also have disruption of the intercellular tight junctions, leads the fluorescein to go into the cells as well. And this is very helpful for tear breakup time. And I like to think of fluorescein for the cornea specifically, although you can see conjunctival epithelial defects and staining there. Although I tend to use either really lissamine green. So the other stains include lissamine green and rose bengal. Both of those stain live epithelial cells that have lost their mucin covering. They'll also stain dead cells or epithelial defects. And they're better at staining the conjunctiva, especially in dry eye, or SLK, superior limbic keratitis. And then I tend to use lissamine green mainly because it's less painful or irritating to patients as opposed to rose bengal, but both really function very similarly. So again, fluorescein I like to think about for the cornea, and lissamine green I like to think about for the conjunctiva, but make sure to look at both areas because you can see they highlight slightly different things. You can also look at the staining patterns for fluorescein. So you have superior staining can highlight SLK or whether or not there's a foreign body. It can also show, you can think about floppy eyelids in these patients. And then if there's interpalpebral staining that's in between the eyelids, you want to think about dry eye or exposure or neurotrophic component. If there's more staining inferiorly, you want to think about blepharitis, dry eye, and if there's diffuse staining, you can think about viral or toxic, so medication-induced, or severe dry eye disease. And then you can obviously also use fluorescein staining for contact lens evaluation. Schirmer's are, again, measures the production of tears. So you can have with or without anesthesia. You want to make sure that the fornix is dried before placing the Schirmer's test. And you place the strip in the outer 1/3 of the lower eyelid. And then you keep it in for 5 minutes and then remove it and you measure the distance the tears have gone. Without anesthesia, it measures both basal and reflexive tearing, and with anesthesia, it measures just basal tear production. And the Schirmer's test is 90% specific and only 25% sensitive, but it's a pretty helpful test for these patients. The Ocular Surface Disease Index score is another useful tool. This is a validated or a similar tool. It's a validated dry eye disease questionnaire. It really gets to the symptoms of dry eye disease. And what this is it's 12 questions. You ask, it discusses or asks the patient to describe their pain over the last, or changes over the last week. The first 5 questions look at the symptoms, so sensitivity to light or grittiness. Then you look at how it affects different activities of daily living. And then you look at the last 3 questions, evaluate specific locations or situations that the patient may have been in the last week that have caused them some discomfort from their eyes specifically. You then add that up and use some of the scores, and you can decide if they're normal, mild, moderate, or severe. Corneal esthesiometry is a measurement of corneal sensation, and it's important to use to diagnose neurotrophic keratitis. It's important to do this prior to instilling any anesthetic, topical anesthetic, as obviously that would change the results. There are multiple different kinds. The quantitative approach is the Cochet-Bonnet, and then you can also use sort of cotton tipped applicator or dental floss methods, which can help if you don't have Cochet-Bonnet readily available in clinic. Just to review quickly how Cochet-Bonnet works, that's the photo here. You want to extend the filament out completely to the full length of 6 centimeters, and then you slowly retract the filament in 0.5 half-centimeter steps until the patient can feel the contact on the cornea, and then you record that length, and then you compare both eyes. You want to do it in 5 different areas of the cornea: centrally, superior, temporal, inferior, and nasal. And then once you're completed this, you then sterilize the filament and retract it back into the device so that it doesn't cause damage to the filament. There are also newer tests for diagnosing dry eye disease. You want to think about osmolarity, and then inflammadry, which is MMP9. This works like a sort of like a COVID test, where you take a sample of the tears, And then there's a buffer that's used, and then you can see different grades of positivity. And then you can also use conjunctival or corneal impression cytology. This is more experimental or more in clinical studies. But you take filter paper, you place it on the conjunctiva or cornea, and then it can pull off mucus or epithelial and goblet cells from the surface of the conjunctiva. So like we've talked about already, but in order to manage ocular surface disease, just like diagnosing it, you have to be able to categorize it because the treatments should be tailored to the underlying etiology. So going back to the TIFOS DUES 2 recommendations, this is one way to think about it. So their recommendation includes educating, step 1, which is educating the patient on the condition, thinking about the management, treatment, and prognosis. So you want to modify the local environment, think about the diet, think about any options that you have to modify, like the systemic and topical medications that could be causing the symptoms. And then you want to look at lubrication of the ocular surface, treating the meibomian gland disease with lid hygiene and warm compresses. If that's not adequate to treat, then you want to think about adding preservative-free artificial tears, tea tree oil if there's a component of Demodex, and then preventing loss of fluid from the eye with punctal occlusion or moisture chamber goggles. You can also think about nighttime therapies like moisture chambers or ointment. And then there are also in-office therapies like IPL or LipiFlow. And then you can also use prescription medications like topical antibiotics or antibiotics and steroids, topical steroids, and multiple other options that we're going to go through in more detail. If those aren't helpful, you can also then step up to serum eye drops or a therapeutic contact lens. And then you can think about topical steroids for a longer duration, punctal occlusion, amniotic membrane, or other surgical approaches like a tarsorrhaphy, which can be very helpful depending on the patient presentation. This is the DUES 2. This is another way of thinking of breaking that down more visually because, but again, you want to ask the questions and understand the history. Then you want to look at the risk factors, and then you want to use a dry eye disease questionnaire like the ocular surface disease index, and then you want to look at specific tests like tear breakup time, tear osmolarity, ocular surface staining, and then you want to go think about the subtype classification, and then that can help determine which direction to be most focused on in the therapeutic approach. So again, thinking about evaporative versus aqueous deficient dry eye disease, these are current approved medications and things to think about as far as biomarkers or tests that can help with this. So for evaporative versus aqueous deficient dry eye, you want to think about for evaporative dry eye, the treatment that's FDA approved would be MIBO or perfluorohexyl octane. And you can use different ways of diagnosing this. I would think about tear osmolarity sort of to correlate with that. And on the other hand, you have aqueous deficient dry eye disease, which has more therapeutic options like cyclosporin, lifitegrast, steroids like loteprednol, and then there are other therapies like nasal spray with varenicline. Oh, and then you want to think about MMP9 as a potential biomarker. So that's inflammatory as a potential biomarker for aqueous deficient dry eye. That's specific for inflammatory dry eye disease. So putting this more all together, so dry eye disease treatments, you want to, again, think about aqueous deficient dry eye versus evaporative dry eye. If we look at aqueous deficient dry eye, the main goal is to replace the tears. So you can use artificial tears, serum tears, steroids, cyclosporin, lifitegrast. There are different delivery methods. Most are topical eye drops. There is a nasal spray. Um, and then each one has a slightly different goal and different side effect profile. So it's important to tailor the medication to the patient. And then moving over to evaporative dry eye, the goal is to prevent loss of fluid from the eye, loss of the tears from the eye. So you want to think about warm compresses, eyelid scrubs, systemic therapy like doxycycline and perfluorohexyloctane. The topical eye drop is perfluorohexyloctane, which is a semifluorinated alkane, and the goal is to reduce tear evaporation on the ocular surface and stabilize the lipid layer of the tear film. You can have blurry vision and eye redness with that. Again, each of these therapies has their own risk factor profile. So with steroids, you have an increased risk of cataract formation or increased intraocular pressure. You can also have with cyclosporin or lifitegrast, you have burning and hyperemia of the conjunctiva and blurry vision. With a nasal spray, you can have increased varenicline. You can have sneezing or coughing or throat and nose irritation, which patients really don't can have real challenges with. So we're going to quickly go through some of these in a little bit more detail. So artificial tears, preservative-free artificial tears is my general recommendation, especially if the patient's going to be using this more than 3 to 4 times a day. This is obviously relatively benign. I know more recently there's a concern for contamination in some artificial tears, but in general, this is a pretty safe approach, and patients tend to tolerate this well. You can also think about lubricating ointment at bedtime, and just make sure to tell your patients that they can have some blurred vision, and it should probably be the last thing that they do after they've instilled all the rest of their drops. Cyclosporin, there's 2 different concentrations, 0.05% and 0.09%. It helps decrease inflammation, so that's something to think about when using this for treatment. And then patients with really severe tear film insufficiency can't tolerate this oftentimes because of burning. So you want to educate them that that is a possible side effect. And also it takes some time to reach full efficacy. I like to start patients on a topical steroid at the same time that I start cyclosporin, just to sort of help them get through the first little bit where they're not going to see as much of any efficacy from this drop. Then we have lifitegrast, which is also anti-inflammatory, but not a steroid. It inhibits immune cell extravasation onto the ocular surface and inhibits T cells, and it has a preservative-free formulation and has a lot of the same side effect profile as cyclosporin. Corticosteroids for dry eyes. I think that these can be incredibly helpful. You can use a pulse therapy, so during active inflammation, so you can use it briefly and then stop, or you can use it for longer durations, especially if you use one of the more steroids with less of a side effect profile, like loteprednol or fluorometholone. You have less problems with intraocular pressure and less cataract formation. And this, to me, if everything else hasn't worked, it's worth it to try a trial of steroids, of these steroids. Next, you want to think about punctal occlusion. You can have plugs. There are different forms. There's dissolvable or temporary plugs. Those are collagen or hydrogel based. Semi-permanent are silicone based. Intracanalicular plugs are also possible. And then ultimately you can have permanent plugging with thermal cautery. Another treatment option that can be very helpful is serum tears. This works because of growth factors, platelets, and proteins that are similar between the serum and healthy tear film. It's a blood-derived material. and supports cell growth and health. There's autologous and platelet-rich plasma, and there are multiple other different kinds. But basically, the patient has their blood drawn, it's spun down, you take the serum, and then you mix it at different concentrations with either preservative-free artificial tears or balanced salt solution, and then it gets the patient keeps it in the freezer and slowly uses it until as needed. Scleral contact lenses are an excellent option if the patient's able to tolerate them. They're especially helpful for resistant cases or challenging cases like graft versus host disease. The challenges are really accessing them and having somebody who's able to fit them, and then also handling of the lenses can be hard or challenging or impossible for some patients. There's a neuropathic component of dry eye disease, which is really important. Serum tears can help with that. Contact lenses are helpful. You also want to think about systemic therapy like gabapentin or pregabalin. And then also thinking about lifestyle changes. You want to think about sleep, exercise, hydration. So again, thinking about the patient as a whole. Ultimately, the principles of management for ocular surface disease are fourfold. So replacing the moisture, you want to think about preservative-free artificial tears, gels, ointments, serum tears. You want to think about treating the meibomian gland disease, so looking at the eyelids, treating the warm compresses, erythromycin ointment, systemically with doxycycline or in-office procedures like intense pulsed light therapy. You want to prevent loss of fluid from the eye, so contact lenses, both soft and scleral contact lenses can be helpful. You also want to think about moisture chamber goggles, environmental changes like humidifiers, lowering the height of computer screens. And then you want to think about controlling the inflammation both topically and systemically. So topically, you want to think about steroids, tacrolimus, or cyclosporin. You also want to think about systemic therapy with either steroids or immunosuppression. That's usually done in coordination or collaboration with either rheumatology or another team. Ultimately, which I'm hoping to show you with the next case, is really this gets into the art of medicine is how I like to think about it. There is not one size fits all, and there isn't one simple algorithm that really encompasses how to treat patients with ocular surface disease. Some of it's just from experience, really listening to the patient and understanding the various treatment options and understanding which component of ocular surface disease those treatment options can help address. And then following the patient and explaining to the patient that this is a more of a chronic disease and is a process. So we're going to go through this case briefly. So this is a 79-year-old female who was referred from an outside practice. She had cataract surgery in both eyes and had a history of severe dry eye disease. Her most recent cataract surgery was in the left eye about a month previously, and she had challenges healing the epithelium after the cataract surgery. She had a procara placed by the cataract surgeon who performed the surgery. And then she also came in complaining about bad breath and decreased taste, which were new for her. The medications that she was on loteprednol, preservative-free artificial tears, and ointment at bedtime. Things to note, she had a past medical history of a B-cell lymphoma, a MALT lymphoma, with a recent recurrence. She had undergone radiation and chemotherapy for that. And she had a past biopsy of one of her glands many years ago, but she doesn't remember why, and she doesn't have the records from that. Her vision in the left eye was count fingers at 3 feet. And you can see that there was a central epithelial defect. The next steps that we decided to proceed with were to come off of the loteprednol since she had already been on it to try and increase the epithelium healing, placing punctal plugs, both upper and lower punctal plugs, increasing lubrication, so using preservative-free artificial tears every 2 hours, and increasing the ointment to twice a day since her vision was already affected. So we're less concerned about the blurry vision that can happen from ointment. She then went back to her outside ophthalmologist, which was closer to home, and then came back 4 months later with worsening of her blurry vision, a corneal ulcer in the left eye with a non-healing epithelial defect. Again, at that point, we decided to culture and start fortified antibiotics. And the culture was positive for MSSA and had improving signs and symptoms. She had amniotic membrane placed and epithelial defect improved, and she was restarted on loteprednol. At that point, we did get lab work done, and it was positive for anti-Ro, anti-La, and ANA, and she underwent a biopsy which showed Sjogren's. 2 months later, she then came back with this, you can see that there's a central epithelial defect with rolled edges and some significant thinning. She was found to have decreased corneal sensation. She had a non-healing epithelial defect and neurotrophic keratitis. She continued to have pain. She had a melting central cornea with a new hypopyon. She underwent a penetrating keratoplasty. Post-op, her epithelium actually healed, which was good. And the steroid was tapered down to once a day over the course of a couple of months. 1 year later, she then had a new epithelial defect on her graft. A bandaged contact lens was placed. She was started on moxifloxacin, and we continued the steroid once a day because of the graft. She had a persistent epithelial defect. She was started on oxervate 6 times a day, and 2 weeks later, she came in complaining about burning. I encouraged her to continue the oxervate because the burning was a good sign. She did, because that usually is an indication that that the oxervate is working. 3 weeks later, she came back in with her epithelial defect healed, and she's been doing well since then. So again, my pearls for treatment of ocular surface disease, you want to think about the patient's history, identify the underlying etiology. Treatment is targeted to the underlying cause, and not all dry eye disease is the same and shouldn't be treated the same. So we're going to go back through this patient again. This is a 74-year-old female who was referred from neurosurgery with a history of diabetes. She had left cavernous sinus tumor resection in August. She presented with blurry vision, double vision, sixth nerve palsy, and she came in to see us a month and a half afterwards. Her vision in the right eye was 20/20 and the left eye was 2500. And she had an inferocentral epithelial defect with rolled edges and surrounding corneal haze. She had decreased or no corneal sensation in the left eye. She had the central epithelial defect and port blank. So what treatment would you recommend? Again, we have preservative-free artificial tears, bandaged contact lenses, moxifloxacin, culture, amniotic membrane graft, serum eye drops, scleral contact lens, tarsorrhaphy, and oxervate, or A, B, C, and D. Again, this is the first thing that you want to do when this patient presents. So that's right. So A, B, C, and D is a good option. So about 60% of people who voted got that right. All of these are really good options for these patients. It's just a matter of figuring out what to do first, and in what order. And some of them are limited by what you can discuss with the patient and how you can ultimately help them. So like a tarsorrhaphy can have great outcomes, but you need to convince the patient to undergo that. Thank you. So see if I can find them. So at this point, we're going to go through the Q&A session. So if there are any questions from participants. I don't have, so the first question is if there are any examples or pictures of staph marginal. I did not include that, but there are definitely examples through the American Academy of Ophthalmology has some examples on their website. You want to think about staph marginal when there are infiltrates along the limbus or where the eyelid hits the cornea. Those are usually really helpful in seeing that. You can also look at both eyes and see whether or not there are any scars as opposed to active inflammation. The next question is, would red light therapy be helpful in reducing inflammation? That isn't something that I use in my practice.
Looks like there's one question in the webinar chat, Dr. Sunshine.
Okay, let me see if I can find that. Hold on. Using gabapentin for dry eye disease, that's really when there's a neuropathic component. So there are patients that come in with very little ocular surface signs on exam, but lots of symptoms. These can be some of the most challenging patients to treat because they're debilitated by these symptoms, and gabapentin can get to the neuropathic component of this. So those are really the patients that you want to think about with gabapentin. It's a very small subset of patients, but they really can be the most challenging. But that's a good question. Again, all of this gets down to the art of treating these patients. So really it's understanding what the underlying, or trying to understand what the underlying problem is for that specific patient. There isn't one answer for everyone, and you have to tailor both your, you have to tailor the treatment to the person, and some of it is trial and error. So if you try something and it doesn't work, then you need to think about what the next step is. I like to try, depending on what, again, it's specific to the patient. Some patients you need to treat really aggressively, quick, faster, like patients with ocular graft versus host disease, which is a big part of my practice. You want to treat them with steroids and anti-inflammatory therapy early to prevent long-term complications. But then there are other patients where you want to sort of go in a more stepwise approach, where you want to start with artificial tears and slowly work your way up to more aggressive therapy. Are there more questions? So there's a question about whether or not there's phenol threads versus Schirmers. I tend to use Schirmers on my patients. I have not used phenol thread in clinic. I have used it in my lab, but I think Schirmers is sort of just easy to use and pretty standard. My own experience with Xdemvy, I've had really great experience with it. I think that's what you're asking there. And it's so if I'm concerned that a patient has Demodex blepharitis, I will start them on Xdemvy. I've seen really impressive results, and so that's been a nice addition to our options for therapy. I'm not sure I understand the other question. Any other questions? So I want to thank everybody for joining, and I hope that this was helpful. If you have any questions, feel free to reach out, and I'd be happy to discuss more offline. Don't forget to take the post-test questionnaire so that you can receive your CME credit for this. Thank you very much.